Good morning to the Polonovita and fellow students. Today, Raymond Chan, we will be covering the patient details, her presenting complaint.
Mrs. HC is a 71-year-old female. The case is regarding asymptomatic. Mrs. HC is known to. The patient is known to have a heart condition. The patient also suffers from. The patient is currently taking. The patient is allergic to both. During the extraoral exam.
This is an intraoral clinical photograph of Mrs. HC showing the lips with lipstick. This is the second intraoral clinical photograph of Mrs. HC showing the. This is an autopantomogram of Mrs. HC showing the temporomandibular joint.
Thanks, Harrison. As mentioned previously, the significant findings of Mrs. HC, which may be oral liquid lesion, is a reaction to either drugs, dental restorative materials such as amalgam, graft. Lupus erythematosus is an autoimmune inflammatory connective tissue disease that commonly affects feet. Oral lichen planus is a common chronic inflammatory autoimmune disease of the skin and mucous membranes. Carcinoma in situ is a term used to describe the most severe dysplasia where the abnormality. Oral mucosal squamous cell carcinoma is a differential diagnosis that must be included for any.
Thanks, Ray. Special tests and investigations. To establish a provisional diagnosis, additional diagnostic testing is often required to supplement patient history and clinical observation, and also helps to discern between the various conditions which share common presenting features. Firstly, through careful visual assessment, one needs to establish whether the lower left mucobuccal lesion is presenting unilaterally and is isolated from the right lesion, or if the left lesion is an accompanying bilateral presentation of the right buccal lesion. In any case, both of these need to be palpated and assessed for tissue consistency, friability, and tenderness. White scar lesions can arise from mechanical trauma. Hence, it's necessary to question the patient about habits related to cheek biting or consumption of hot or acidic foods. Intraoral signs of parafunction or factitious injury such as white, red, or black spots or irregular inner cheek need to be identified, and according to the clinical photos, there is suspected denuded area with a small black dot in the posterior region of the right buccal mucosa. For this patient, the oral presentation may be associated with underlying systemic condition, and so it's necessary to investigate these factors. The patient complains of itchy skin, and so if cutaneous lesions are identified, then a referral may be made to an allergy specialist or dermatologist for skin patch testing to identify the causative agent. Cutaneous lupus can present as thick red scaly rashes, and that can lead to scarring. Rash associated with lichen planus would be characterized by small, flat-topped polygonal bumps that grow together into rough scaly plaques. Contact allergens in dental restorative materials, such as amalgam on the 3,6 and 3,7, raises suspicion of lichenoid reaction, and so epicutaneous patch tests of substances used in dental practice, as well as amalgam, can be performed to diagnose contact allergy. A full blood examination is needed to determine the presence of any deficiencies, assess the patient's immunological status, and potentially exclude or confirm the presence of immune-mediated disorders. If lupus is suspected, then preliminary complete blood cell count and testing for autoantibodies against double-stranded DNA would be required. Hematological testing can also help to detect viral infections, such as hepatitis C, which is a trigger for lichen planus. The clinical photos showed the white lesion to be subjacent to teeth that were heavily restored with amalgam. As such, mercury of dental material may have presented a systemic exposure, and so serum compatibility testing may be performed. While the diagnosis of a specific condition may be made by its clinical appearance, histologic examination of lesional tissue may be helpful when common characteristic features are observed or when trying to exclude malignancy. As a screening modality, Brush biopsy is performed first and may help to identify the presence of hyperkeratotic lesions or to determine if a suspected lesion is precancerous. If findings are inconclusive or if atypical cells are detected, then an incisional biopsy may be undertaken for histopathological evaluation and to confirm the correct diagnostic finding. The biopsied lesion is examined microscopically, and in oral lichen planus, histological findings would indicate parakeratosis, fibrinogen deposits along the basement membrane, severe thinning of the epithelium, liquefaction of the basal cell layer, as well as band-like subepithelial infiltrate of T lymphocytes. In lupus, however, the inflammatory infiltrate would extend deeper into the underlying connective tissue, and this would show a perivascular pattern as well as basal cell vacuolization. When basal cells undergo dysplastic proliferation with cytological atopia, then carcinoma is considered. For the purpose of establishing a provisional diagnosis, our patients' presenting features are consistent with either a lichenoid-related process or an iatrogenic pathological process. However, for the purpose of comprehensive case analysis of all pertinent information obtained, Emile will now detail the management strategies for all the oral conditions listed in our differential diagnosis.
Thank you, Reem. My name is Emil. Today I'm talking about patient management. Lichen planus and lichenoid reaction management. The principal aims of widespread severe recalcitrant lesion can be managed with the management of discoid lupus erythematosus is aimed to improve the patient. For recalcitrant disease, immune suppressants and immune modulators should carcinoma in situ. If the biopsy shows a lesion to be oral squamous cell carcinoma, multidisciplinary approach that includes surgery